So I'll be talking about a titrated and sequential protocol for subthreshold yellow micropulse laser in chronic CSE. So this was done to assess the safety and the efficacy of a sequential 577 nanometer subthreshold micropulse laser with a reproducible laser protocol to treat both juxtafoveal and subfoveal leaks in chronic CSE. So we treated 60 eyes of 57 patients with an age more than 18 years, duration of symptoms more than 3 months, and with an active subfoveal or a juxtafoveal leak on fluorescent angiography. So we used a 5% duty cycle, a 200 millisecond spot size, and a duration and 100 micron spot size, with a threshold burn in the micropulse mode outside the arcades. This was followed by treating the leak area on FFA with 50% of the threshold power. This was followed by follow-up at 1, 3, and 6 months with BVCA, OCT, EDI, and FAF. And if there was a suboptimal response, you increase the power by 10% of the base power to a maximum of 80% of the threshold power. And the outcomes measured were subretinal fluid height, BVCA, OCT, central choroidal thickness, central macular thickness, and any hypo-autofluorescent lesions on FAF, which indicates an RPE damage. So we looked at the anatomical outcome of either complete resolution of SRF, partial resolution, or a non-resolution, and a functional outcome as in a one-line, at least a one-line improvement in Snellen's, and a safety profile by serial FAF for assessment of any new hypo or hyperfluorescent spots compared to pre-treatment FAF. So out of the total of 60 eyes of 57 patients, majority of them were male. Mean age was 44.53, plus or minus 7.6 years. Mean number of sittings were 1.55, plus or minus 0.89, and the mean follow-up period was 9.96 months. Overall, we had a 80% success rate with a 10% partial resolution and a 10% non-resolution. And out of the 80%, around 29% of the patients had a recurrence of fluid at the end of the study. So at the end of 3 months, there was a significant change in the SRF height, the BVCA, and the central macular thickness. And at the end of the study, there was also a significant change in the SRF height, BVCA, central macular thickness, but central choroidal thickness was not found to be significant. And the presence of fibrin at the baseline visit also showed a statistically significant association with the recurrence as the final outcome. But PED did not, while even we felt clinically to be significant, did not show a statistically significant outcome. So when you look at the literature, you find that there's a lot of variation in how it's been treated. Some use fixed power, some use titrate in the continuous mode, followed by doubling the power, some treat in micropulse mode. There's variation in duty cycle, duration, spot size. Some treat the whole SRF area, or some choose an arbitrarily 100 microns on the macula and leak area if it's outside. Retreatment has been done, but usually protocol is not mentioned. So our technique of using a 5% duty cycle was done to ensure safety, and it was also FAF guided to study RP toxicity. And this titrated laser protocol to 50% is basically individualized to each patient, as the threshold power can vary from patient to patient and race to race. And in case of non-resolution, a sequential increment with 10% increase in power was done. And this treatment was targeted and confined only to the angiographic leak. So sequential titrated subthreshold micropulse is safe and effective in subfoveal leaks with an 80% anatomical success. And the current drawback of challenge in using micropulse for chronic CSE is that the absence of consensus among the variable treatment protocols, making it difficult to be reproducible. And this makes a protocol individualized to the patient and reproducible in any clinical settings, and sequential retreatment is a key to increasing the success. And this is also, becomes more important in the current scenario where PDT is not freely available. And the 29% recurrence rate is because mainly this micropulse does not address the underlying choroidal pathology. Thank you.
It's a good study. I just want to know if the fluid is regressing, what do you treat it as? Whether it is responding or it's not responding?
So if it's almost after 1 month.
If it is not yet gone down totally.
Yeah,
let's say after 1 month.
After 1 month, if it's suboptimal, less than 50%, we treat it again at the same leak spot on the FFA with 10% of increase in power. So we
even the reduction of fluid doesn't, reduction of the height.
If it's less than 50% reduction, we increase the power once more.
So we wait.
We 1 month we give.
Okay, because when you're repeating it, you're not sure whether it is this treatment or the previous treatment
Yes.
which is effective.
So again, we'll see him after 1 more month.
Fine. Thank you.